Oh, hey, Chris.
Hey Chuck, how are you?
I am well. It's been a little while since we've recorded.
I know people are getting slapped. People have been on spring break. It's been a weird moment right now.
Yeah, let's not talk about the slapping. I think that's been over discussed already.
We'll be the only podcast that does it. So how about that?
That
Have you
is
been
good.
getting some good rest?
I have. We had a really nice spring break with my entire nuclear family and my wife's parents and her brother. Went down to the Caribbean. I know we sound spoiled, but we don't get away often, so it was really a great trip.
That's fantastic. Well, it's the right time to do it. Who knows what's next in terms of COVID stuff, but it does feel like St. Louis at least is opening back up. Went out to the store and I was the only guy in a mask, and that felt good to see that. So
It is true. Masks are in the Midwest are getting to be scarce. But like you, I am still wearing them in public.
yeah, exactly. I'm just so used to it now. I mean, I don't know. I kind of like not having a cold. I haven't had a cold in a couple of years, which knock on wood, is a pretty incredible feat for a dad with two very young children. Who usually would bring home a bunch of stuff.
Yes, that is absolutely true. It's really, really incredible. And I'm like you, I haven't had a cold in a long time, so it feels good.
Practice has been busy, or have you been pretty steady, or what's that like?
Yeah, it's interesting. Practice has been busy, and this week, I was out last week. I'm back this week, and very busy. I had to take some, meeting time and academic time, and add some cases on. Full two-room day tomorrow with great cases. So yeah, been busy. What about yourself?
Pretty busy. I mean, I'm still at the point in my practice where, I definitely feel it if I'm gone for, a clinic or two. And not only do I feel it in terms of case volume, it's also a little crazy to try to get people in. Last month, because some way the schedule fell with holidays and stuff, I ended up adding on a clinic on a Wednesday, which is not my normal day, just to try to even things out, and, stop my team from going crazy.
Yeah, very true. Those ups and downs are a little flatter for me now, and I think we've talked about this, but it still makes me nervous. If I don't have a full OR day or clinic is less than crazy, I don't like it. Maybe I need to adjust and accept it, but I still don't like it.
You seem to thrive on the crazy, though.
I know, and I think I'm getting too old to be thriving on the crazy.
So, what does the number 2,926 mean to you?
It's really incredible. I saw that, although I don't think I had it down to the exact number that you did. It is our downloads last week. Really awesome.
Yeah, fantastic. I think it was Steve Moran who really put it over the top with his recent episode. We'll have to give him some extra credit for that, for those of you listening at the Mayo Clinic.
That's right. No, look, we are grateful for the audience, and we're grateful that we honestly seem to be continuing to find new listeners. Clearly, we have not saturated the potential market, even though that feels like a lot of downloads.
Well, it feels great, and it's good to know. For everybody, we certainly appreciate all the feedback that you give us. We love it when you leave us reviews. We're up to 127 ratings on iTunes, which is fantastic. And we have some new reviews we wanted to share. So one is, I think I planted this one, but this is from Nisha in California. And this is a 5-star review. And she said, "Thank you for sharing your experience. I appreciate that you keep it engaging and real." So there's Chuck keeping it real again. "Hearing the descriptions and decision-making behind the surgical procedures is so helpful as a therapist. I wonder if you see 3D printing useful in your practice, and if so, how?" So let's answer that in a second. "Looking forward to hearing your talk about nerve transfers at our conference in California." So Nisha, and I'm sorry for mispronouncing your first name, but she was kind enough to invite me to give a talk to the California Hand Therapy Group for their annual meeting, which is about a month from now. So I'm really excited to do that. We'll be talking about nerve transfers, and the therapist that I work with routinely, Jamie Findice, is going to join me to give her thoughts. I told her I would do all the heavy lifting with the slides and the talking. I would just ask for her opinion, but super excited to do that. And thank you for the review. And Chuck, 3D printing in your practice?
Well, first, is that a in-person visit, or is it a Zoom?
It is a Zoom, although, gosh, I wish it was in person. Nothing like California.
Yeah, still that's great. That'll be fantastic. Yeah, I got into 3D printing. It really makes me feel good to say about 10 years ago when I worked on some projects regarding prosthetics for kids. And we created and published actually a really early paper on 3D printed prosthetics that were myoelectric. And they were simplistic, but we really had something going. And it's a classic story that it was something I felt passionate about. I did not find any support from the Shriners Hospital, unfortunately, which was confusing to me. And we had a good partnership with some people who knew a lot about mechanics and engineering. And I partnered with some folks at the engineering school here at WashU. And then unfortunately, one of the key partners left. And it just kind of fizzled. And it's not, sometimes the partners are key. And despite my passion, I only brought one part of the equation to creating a successful enterprise. And so it fizzled. And since it fizzled, there have been commercial products which have been developed, which are far more impressive. But it was something I had a lot of fun with.
Yeah, that's super interesting. And I'm sorry to hear that your collaboration fizzled. That's kind of how it goes in academics sometimes. But yeah, that's great that you got to pursue that. I mean, we had an interesting grand rounds. It might have been about 6 or 7 months ago from a presenter from Duke, foot and ankle surgeon. I think his name's Sam Adams. And he gave a great talk about, the applications of 3D printing for custom prostheses and for, in trauma settings. Super interesting. It looked incredibly challenging and a lot of surgeon time with the engineers to try to design something like that. I think the big issue is typically going to be cost and generalizability, but maybe one day. In my practice, David Brogan, our partner, who does a lot of lab-based research, did some really cool stuff with 3D printing and nerve scaffolds. And that's some work that's been put on the back burner for a bit, but it's super interesting because, if you think about it, if we can find the right material and you're looking for something that'll allow an axon to regenerate down a specific channel, so say you have like the sensory component of the ulnar nerve and the motor component of the ulnar nerve, and making sure that you get point A to point A and point B to point B, it's a natural application if we can make that work. So, that paper is on its way out, but super interesting stuff. And maybe there will be an application. I think there are lots of ways as 3D printing becomes more accessible, the engineering time goes down, it becomes more automated. There's gonna be tons of applications in surgery.
Yeah, and the strength of the materials and the applicability of various materials matters a lot. One of the things I really enjoyed talking about, we had a great congenital clinic today at the Shriners Hospital, and one of the things I really do like talking about with patients are prosthetics. And had a 3-year-old come in with her mom, and she really wanted a prosthetic, which is really unusual. It used to be that every kid, when they were 6 months of age, they got a prosthetic, and it was a kind of passive prosthetic that didn't do much. And now we just provide prosthetics when kids ask for them. So we had this young child with some brachydactyly talk to the prosthetist. But what's been it's really a complete paradigm shift in prosthetics, which goes to 3D printing. And I know I'm getting a little far afield from the question, but it used to be our goal was to make a prosthetic that almost was invisible, and it was the same skin tone and very subtle. And now with the 3D printed, we make prosthetics that look like superhero arms. And there's pride in your cool prosthetic. It's just such an interesting phenomenon. And to get kids excited about the potential for a prosthetic, it's been super fun to watch.
Oh, that's a huge hump to get over. I mean, absolutely. That's going to be an interesting evolution of that in your practice. And I hope more kids who'd benefit from it are able to get it. I'm not sure what the cost is at this point and how often it's covered, but that'd be great.
Yeah, for just a passive prosthetic, it's actually incredibly cheap. Prosthetics can be super expensive, 35, 50,000 for the fanciest. But for 3D printed, it's just a matter of a couple $100. So not expensive, but to some degree you get what you pay for.
Right, right. So one of the segments that's always a hit are the surgical technique episodes. Based on a recent case list, I thought it'd be interesting to talk about radial tunnel decompressions.
I'm shocked. Are you suggesting we talk about a nerve topic?
Well, we will throw in a little bit of tennis elbow technique, because sometimes, as we've talked about on this podcast before, those things come into play together. So, there'll be a little sportsy stuff in there, or weekend warrior kind of things in there for you.
Absolutely. So we're going to, again, for this segment, we're really talking about the surgical technique and not really getting too much into the indications or
Right.
rehab, just really how we get the job done.
Right. So you say you've made the decision to bring a patient to the operating room to release their radial tunnel. How do you think about how do you set up the room? Is there anything particular that you do? I personally use a sterile tourniquet, mainly out of habit, but I don't think it's always necessary.
Yeah, I do not ever use a sterile tourniquet. I don't know where you learned that from. I use a non-sterile tourniquet, and I use a standard arm table. Nothing fancy for me about the setup. For me, the decision, and I'm curious as to how you think about it, if it is an isolated radial tunnel that is without tennis elbow, then I really like the anterior approach. And if it's a situation where there's tennis elbow and radial tunnel, then I performed one of the posterior approaches. What about you?
So do you not like to release the entire radial tunnel? Is that what you're trying to say?
I'm trying to say that there's a distal end. You're saying there's a distal end to the radial
Yeah,
tunnel?
yeah. That point when I have to go back and do redos, that one.
No, I feel strongly that the distal end of the radial tunnel is largely a myth, and clinically, you can usually tell where the pain is where the compression point is. And I'll be honest, I don't think I've ever been impressed that there's a point of compression distally.
What if there was a way to decompress the entire radial tunnel without missing any part of it? Is there a way? I don't know.
There is, Dr. D, and we can talk about that, and we can talk about the pros and cons of a complete release and the beauty of the anatomical approach from anterior versus the potentially beautiful approach from dorsally.
So so for the listeners that may be less familiar with the surgical approaches, so when you say anterior, you mean anterior or volar to the brachioradialis, is that correct?
Yeah, let's talk, if it's okay, let's talk through that approach first. I think it is a really straightforward approach, which is nice. I think the anatomy is pristine. And so for me, I make an incision from really I'm trying to show this for our YouTube watchers, really from the antecubital crease at the ulnar edge of the brachioradialis, and it's usually about 4 centimeters in length. Do you ever go volar or anterior, or do you always go dorsal?
As our partner would say, never say never, never say always. But if I'm doing a radial tunnel decompression, I will pretty much always go anterior lateral, which I think gives me the best of both worlds. And the skin incision is such where if I truly wanted to do a posterior approach, I could through the same skin incision, just through a separate surgical window between the muscles. The approach you're describing, the anterior one, is the one I use when I'm doing median to radial nerve transfers anyway. And I think it's a great approach because you really get to see that SRN coming off, coming off of the radial nerve proper, or I think the easier way to do it is to actually start distal to proximal and find your superficial radial nerve right underneath the brachioradialis distally, because it's much more defined there and there's less of the vasculature kind of crossing in your way. And then go from retrograde almost, so distal to proximal, trace your SRN up, and then find where the PIN is coming kind of more radially and deeper off, and you'll be able to see the supinator fibers at that point. So I like that approach. It works really well. It's just, in the setting of a radial tunnel, I tend to use an anterolateral approach.
Yeah, so I agree with everything you said. The concept of finding a smaller distal branch and tracing it back to the main branch, I think, is a great technique. I use it like you do for the superficial branch, the radial nerve hiding right under the brachioradialis in this situation. So easy. The other time I use it is I'm finding the radial nerve proper in the arm posteriorly. I find the posterior brachial cutaneous nerve laterally and trace it back to the radial nerve proper. It just makes things much more straightforward. And so I love that technique. I love that you brought that up.
That was described by your co-author for your Hand Society textbook on the elite athlete that you never signed for me. Michelle Gerwin Carlson wrote that paper when she was just Gerwin.
Absolutely.
Which is funny when the residents at HSS would quote it as Gerwin, and she would be in the room. They wouldn't know it was her. It's hilarious.
That's funny.
So yeah, I mean, I think that for those that in terms of points of compression of the radial nerve, the first thing you're typically going to encounter, almost always, like you said, Chuck, it is the leading edge of the supinator, the so-called arcade of Frosch, that fascial band that can compress. And most of the times, the PIN is running in between the superficial and deep heads of the supinator. The thing that I think that is a little bit more challenging to manage are the leash of Henry vessels that typically always cross exactly where you don't want them to. I think just being real careful with the bipolars, sometimes using some surgical clips can be very useful, but you want to make sure you have a good handle on those. And one of the things that I tell our trainees is that I don't like to start clipping stuff or buzzing stuff until I've seen my PIN proper, just because I know the orientation, the vessels will tend to run more transversely. The PIN has more of an oblique course. I just want to be sure. So I do like the SRN, kind of dance around the vessels initially, find the PIN, and then take care of my vessels.
Yeah. So let's just finish the conversation about the anterior approach and then we can switch. So we make our longitudinal incision, we find the superficial branch radial nerve, we trace it back to the radial nerve proper and decompress the radial nerve proper. You can go pretty far anterior, which are limited, and I'm sorry, pretty far proximal with our limited incision. And then we come back distally, find the posterior osseous nerve, trace it to where it enters the supinator. And in doing so, by definition, you're addressing any quote unquote fibers branches at the radiocapitellar joint, any issues with the ECRB, the medial side of the ECRB, but really you get to the hallmark of the leash of Henry and the leading edge of the supinator. And I'm like you, when I go anteriorly, I do something with that leash of Henry, and usually I hand tie it with 2-0 silk. I'm not a huge fan of leaving clips in. But I do divide it, tie it, and then proceed on to my decompression. Interestingly, when I go from dorsal, I usually leave it intact, which is maybe I should, maybe I shouldn't, but I always release it when I go from anterior or volar. What about you?
Yeah, when you're going from dorsal, I think it is you're working a bit of a deep hole there in terms of trying to tie and clip, and I think because you're not using that as your main access point to decompress the nerve, I think it is less critical to do it from the dorsum. Although a purist would say you should, of course, do the same thing regardless of where you're approaching it from. I kind of go back and forth about the clips versus the ties. And this is not a knock on our trainees or anything like that, but I think the ties can sometimes be a little bit unreliable because our trainees are just not used to tying off small vessels as frequently. And that was one thing that was hammered into me in training when I was at Memorial. They were big on tying everything by hand. So I got a lot of reps on tying. So I'm very comfortable with that. But I think sometimes in terms of moving a case along, if we have a little more time, we'll do the hand ties and I'll make sure they are perfect. And I think it's a good educational opportunity. And for those of you that are surgical trainees that are listening, practice as much hand tying as you can, because when you need to do it, you'll really need to know how to do it, otherwise, I think the clips, are quite useful. I don't feel great though about leaving them in because it is right on top of the nerve. So that is one area where I kind of wrestle back and forth with.
Yeah, and I agree. And if for those of you keeping track at home at our cost per case, we have Chuck in one corner who uses a reusable non-sterile tourniquet and hand ties with 2-0 silk tie. That's about $1. And Chris with the sterile tourniquet and the clip
Which can
applier.
still be reused, okay? You know that we reuse it.
Come on, I got my tally going.
And I'll take the hit on the clip applier. That's fine because the saved OR time actually balances that. So
It might.
so how do you manage your supinator?
Yeah, that was
in terms of the fascia, the muscle, and I think one of the points that we always talk about in our anatomy lab is the orientation of the supinator fibers relative to other muscles surrounding, as well as relative to the PIN itself.
Yeah, I carefully isolate the PIN and try to understand its course as clearly as possible, and also look for branches, which I think are that point is not emphasized as much as it should be for those of us who are not nerve gurus. There is always a fascial band that is real, and to me, it's almost always the site of compression. So I will look for any fascial bands and release them carefully, usually with scissor dissection. And then I simply look for any other potential compressive elements. I do not release the entire supinator, as has been described and as some recommend. I do try to put a retractor into the supinator, that superficial head, and assure there's nothing distally that I can feel or see. And as I stated before, I just don't think that's a regular occurrence. So I keep it simple, leading edge mainly, but look for any other fiber strands within the body of the supinator. Does that resonate with you?
Yeah, I guess I agree with that, except I do try to be very good about getting to the very distal edge. Mainly because I'm there, and in the uncommon, I admit it is incredibly uncommon for that to be the point of compression, distally that is. But I'd rather, if I can get there, I'd rather do it at the same time. But I totally understand many people do not. I do release I divide the supinator muscle using a bipolar typically, just for hemostasis sake, because that superficial head of the supinator can be quite thick. And I release that. And I think your point about seeing branches coming off of the PIN, typically at that point, it is those branches to the supinator. And again, of little consequence if they were to be sacrificed. But for those that may want to use them at some point for like a nerve transfer or something, that supinator to ECRB nerve transfer has been described. So the more reps you can get seeing that branch, the better, and appreciating its course and its caliber.
Yeah, absolutely agree. So talk us through now. You use the anterior lateral approach, and so specifically, you're working between the ECRL and the brachioradialis. Is that your approach?
Right. Right. So, I think there's a really nice paper that Steve Lee and Scott Wolf did. I think it's back in like 2015, I think, in JHS. And Kat Urch was a co-resident of mine a couple of years behind me, and she was the lead author on that. And when they looked at all the different approaches, so anterior, anterolateral, posterior, they found that about 30% of the supinator distally was left uncut through the anterior approach. Now, that may not be a big deal, but it is useful to know that in the least their limited specimens they looked at, in those 10 specimens they examined, 0 out of 10 they were able to see the distal edge of the supinator. Now, the anterolateral approach is not perfect, and the posterior approach is not perfect, because in the anterolateral approach, I think it was like 3 of them, 3 of the specimens, you were able to see the entire supinator from proximal to distal. So you still missed it in some points. My experience has been that if you really endeavor, you can see the distal edge of the supinator reliably through the anterolateral approach. And then through the posterior approach, of course, you're going to see the distal edge, but you will never, at least in their study, see the proximal edge of the supinator, which I think, obviously, that's the point where most people are super concerned. So that's my rationale for using anterolateral. And when I learned this approach, I learned it from Dr. McKinnon, and she made a point of finding the posterior border of the brachioradialis muscle in the holding area, which I think is super useful, and then marking that out. So, the brachioradialis is hard to get people to fire. So, in this setting where they do have an intact radial nerve, unlike a nerve injury setting, you have them give a thumbs up, and then you have them flex their elbow to activate their BR. And for those of you watching on YouTube, so if you give a thumbs up and you have them flex the elbow, you can see that posterior edge kind of right along here. And you can actually bracket the entire BR. So even if you're not going posterior, it's super useful. And then I just put a couple of dots there, and I center the incision on there. And sometimes, so not always, there's a branch of the posterior cutaneous nerve of the forearm off of the radial nerve that sits in that interval between the BR and the ECRL. And so the posterior edge of the BR is adjacent to the ECRL, and sometimes Dr. McKinnon talks about the brachioradialis having a brighter appearance. I have not found that to be consistent, but it is useful, and it's a fun thing to talk about in the OR. And I love this approach because you can do it largely with a knife, and I really enjoy seeing those planes and the beauty of those planes. And I think that once you start to dig in too much with tenotomies, and if you're not perfect on those first few passes, you can actually create a not so beautiful dissection that can be traumatic to the muscle. So I'll start that with the knife, that BR ECRL, and once I get that open, I will take a freer and just kind of gently glide through to make sure I have the plane, and then bluntly sweep through with the finger, and then get some deeper right angle type retractors, either like a Langenbach retractor for those in the orthopedic world, or what others call like a down curve retractor, but something basically to sit down that's narrow and deep, and then pull open that window. And it's beautiful. You automatically not automatically, but you will reliably be able to see that, that arcade approach. And then basically the same dissection continues as we described before.
Yeah, I like how you describe that. I think the biggest pearl, at least for me, is something I do all the time, which is I mark incisions in the preoperative holding area. Patients love it. If you're not doing it and you're a surgeon, you might want to try it. So not only do I write yes, I mark my incision in the preoperative holding area. It gives patients a sense of what we're going to do. Hopefully it's not coming as a surprise. It's another fail-safe against wrong site surgery, and it's helpful if you're doing trigger fingers or multiple trigger fingers, or as Chris said, when you're doing something like this, really useful. And I love your description. When this approach works, and I think the more experience you get, the more reliable it is, it's a beautiful thing. It's a deep hole, but it's a beautiful thing. You can go wrong, as Chris implied, and kind of get into the muscle bellies or not find the interval. And then it can get very frustrating and concerning. Ultimately, you go back to your basics, you make a longer incision, and that can help you identify that interval more reliably, and then you work proximally. But I think that's well described, and I think that is a great approach. I totally agree.
Yeah, I think if you're getting to the point where your anatomy planes are a bit distorted, given some prolonged efforts that have not been successful, I think going to the anterior approach is the, very low threshold to switch over to that, because I think that allows you, much more familiar anatomy, less deep of a hole, and then gets you back on track. And then, releasing the rest of the supinator. And then, you can release the undersurface fascia of the ECRB through that window, because, it's lying right on top of the supinator fascia that you already released. And some would believe that that might be enough to, take care of any tennis elbow symptoms. I'm not convinced. I think you got to go a little more proximal and really get the ECRB off of the bone.
Yeah, I totally agree with you. I don't rest on just that. If I'm there to do two operations, I go a little more proximally and address the ECRB as you suggested. Is there ever a role for you in a brachioradialis splitting approach, as has been described?
No, except if we don't get the planes right, then it becomes a radialis splitting, and that's how we dictate it. But I haven't used that. I thought the question you would ask was, is there a role for the posterior approach? But before we get to that, is there a role for a BR split for you?
No, I've tried it honestly because a lot of people talk about it and it's written about. It creates a bigger, it creates a really deep hole, and the muscle split is never as smooth as I want it to be. And maybe there's someone out there who can provide some technical pearls, but no, I've tried it and don't like it. So I'm either anterior or anterior lateral, as you said. I've also done the dorsal approach or posterior approach, and I found that reasonable, but I like this approach better.
Yeah, I mean, I think that muscle splitting approaches, theoretically have a risk for hematoma, and in a case where I'm already worried about a hematoma, because even with the dissection that we do, if it goes perfectly, you're still encountering lots of small crossing vessels. I just don't want to take on that extra risk. But again, like you're saying, many people can probably do it quite slickly. I remember there was a surgeon who I worked with in residency who would do deltoid splitting approaches for proximal humerus fractures. And that when done well is a beautiful approach. I want to circle back on your point about marking incisions. I mark pretty much every incision in holding, and for most cases, I actually mark it in the clinic, because some of the qualitative research work that we've done specifically on ulnar nerve, one of the things that my patients dinged me on was not understanding what the incision was going to look like for an ulnar nerve transposition. So based on that feedback, I actually started marking that out with them in the clinic and in the holding area beforehand. And for every carpal tunnel, I do that too, because I think it gives a good teaching point about what to expect, like you said.
Yeah, I think that is such low-hanging fruit for those of you, like I said, for those of you who are not doing it, try it. Patients will really, really like it.
And then I think that for a posterior approach, I mean, do you ever do that? For me, it's really only in a revision setting.
Yeah, I don't have a strong indication to do it. It's not in my regular, so no.
So for those that do it or want to do it, I mean, you're going between the ECRL and the EDC, which is not a perfect and easy plane to find, especially proximally. So if you're going to do it, I like to go distal to proximal on that. And again, use that in a setting of nerve transfer work when we're trying to do like the newer nerve transfer that Bertelli has described about trying to plug in specifically to the deeper branch of the PIN. Sometimes that counter approach is super useful. But it is easier to find distal to proximal. And then you really are looking for that change in orientation of fibers to find your supinator. But you got to be super careful because the PIN is supposed to go deep to the superficial head of the supinator the entire way and then emerge from emerge at the distal end, but it doesn't always do that. Sometimes it can come through the superficial head of the supinator. So you got to be really careful about that.
Yeah, well said. Well said. I have a question about closing, but I don't want to jump the gun. Any other technical pearls about the approach and the
No, I guess the only other question I'd have for you is, I've always laid a lot of crepe about working around the PIN. And in terms of talking to patients about the chance of a, post-operative palsy, because, it's one of those nerves where you look at it funny, it tends to go out. Do you talk to patients about that possibility beforehand? And how, what kind of conversation do you have?
Yeah, let's be clear about a couple of things. First of all, for me when I have multiple aspects to my practice, this would fall in the bread and butter, I would call it, aspect of my practice, often workers' comp. And I probably do 3 to 4 a year, radial tunnel decompressions. And I would say I can only remember 1 or 2 times when I've had a radial nerve palsy and I felt very comfortable, meaning I didn't stress out. I didn't think I'd injured the nerve, and sure enough, it came back. I mention it because I do think you have to be very careful with your retractors, and there is a real possibility in an angry, sensitive nerve that it can shut down temporarily. So I do mention it. Do you?
I mention it, and I mention it when we're booking surgery. I mention it the morning of, and I actually don't let our anesthesia colleagues do a nerve block until I've examined the patient afterwards.
So it's interesting. I absolutely let them do a nerve block because I don't think that's going to change anything. I don't examine them afterwards and understand that and have confidence that, if there is a nerve palsy, I know it's a neurapraxia and it's going to be fine.
Yeah, I don't think there's any other technical things that I do prior to closing. I think if the field is particular, if I'm concerned about hemostasis in the field, then I will let down the tourniquet and get hemostasis. If the case has gone smoothly and we've, seen everything we wanted to see without, too much issue with the crossing vessels and stuff, I probably would, opt to leave the tourniquet up for the closure.
That's exactly what I was going to question. So there are only 2 surgeries that I can think of that I always deflate the tourniquet on and assure that I have hemostasis before closure. This is one of them, and a distal biceps repair is the other. Are there surgeries aside from this one where you always let the tourniquet down?
Submuscular ulnar nerve transposition.
I figured you might say that.
Yeah, and that's the one where I always leave a drain. Just because I think early in my practice, I got burned by a hematoma. I guess we shouldn't create changes in our practice based on one case, but many of us, especially when you're early in practice, get influenced heavily and perhaps unduly by your complications.
Yeah, absolutely. It's a fact of life, even in the most academic of us.
Right. Yeah, and then closure for me, if the patient's habitus allows, I love a little, a 3O monochrome for the deep dermals, and then a subcuticular closure I think is really nice. If the skin and the habitus doesn't permit, then no hesitation to use some nylon sutures.
Yeah, and what I love about this surgery is the rapid recovery. And so this is one where, yeah, for the first couple of weeks I have the soft dressing on, or for the first couple of days I have a soft dressing on. I'll let them take it off, shower, rewrap it after about 5 days. I see them back at 2 weeks, and then I let them ramp up their activities as they tolerate. Do you go more slowly, or do you let them ramp up pretty quickly also?
I go more slowly. I think that I guess I could be a little more liberal with it. It's just a surgery where, I think that there is a fair amount of benefit from the post-operative rest that comes after surgery, in terms of not overdoing it. But, clearly that's worked for you. So maybe I'll reconsider, because patients love being able to take off their dressings 3 to 5 days after surgery, and it makes everybody's life easier.
Yeah, totally agree. Awesome. Another nerve topic in the books. We can't go back and do this one again.
Yeah, exactly. Well, before you, should we save our tennis elbow technique for a different day, or do you want to wrap it into here? Do you want to roll it into some sports thing on a different day?
I don't know. It's not my favorite operation, so we can hit it quickly if you want. It's one of those operations that I don't love because I don't believe I can guarantee the outcome that I want. And what I mean by that is there is a certain group of patients that will have a good outcome when it comes to surgery, but it's not every patient. So I don't love it.
Yeah, I agree. I think I was having this conversation with Tom Hong, the resident that's on service with you right now, and we're talking about when to indicate patients for surgery. And I typically will let them go a solid 6 months before I indicate somebody for tennis elbow surgery. That being said, tennis elbow patients feel awful. Like they hate it. I mean, despite even patients who are very diligent about therapy and have the best therapists and do everything at home as well, it is a real bummer from what I understand. And, I even had some tennis elbow symptoms after some of the snow recently. I was like, oh, this would not be fun. Imagine if I had a raging case of this.
It is not fun for sure. And it is a fact of life for almost all of us. I guess my brief pearls would be, I have done this arthroscopically. I don't usually think it's worth the long run, so to speak, for the short slide. But if there is intra-articular pathology that I'm worried about, in addition to a tennis elbow, I'll do it arthroscopically. Otherwise, I make a pretty darn small incision, 3 centimeters maybe, along the anterior aspect of the lateral epicondyle. I take great care to avoid violation of anything posterior to the midpoint of the lateral epicondyle, i.e. the lateral ulnar collateral ligament. Find the interval between the ECRL and EDC, understanding that the ECRB is just deep to that. And then I perform an elliptical incision of what hopefully is really abnormal appearing tissue. Take that out, debride the lateral epicondyle and lateral side of the capitellum, and call it a day.
Now, do you, when you debride, are you using a rongeur? Are you using are you fenestrating that cortex with anything just to stimulate healing?
Yeah, I do. I'm really trying to create a bleeding response. So I use a rongeur on that area. And it's all, honestly, it all feels like hocus pocus to me. But yes, I do use a rongeur. What about you?
I use a rongeur. Do you? I'm wondering how much of a response we need to create, because when I was doing one of these cases recently, the resident asked me, "Are you going to put that back with a suture anchor?" I was like, "No, I'm not going to put that back with a suture anchor. I just released it, so it would take pressure off of it." But I know that that's a described technique. I think it's the suture anchor insertion that is probably doing the trick.
That's exactly right. That's exactly right. I don't repair anything back either. I do a nice release, feel very good about it. And I do rest those patients. I put them in a soft dressing, but I do rest them, as you mentioned earlier. I think that's part of the good response that we get.
I love it. Well, let's wrap this episode up with either a win or a loss, since we were supposed to end it with wins, but then you keep bringing these losses. So
What loss did I bring up?
you brought one up on a recent episode. I can't remember. I was like, oh, that's sad.
Well, my win is the recent vacation. It is, taking care of ourselves, this goes without saying, is the most important thing we can do to provide great care for our patients and great education for our trainees. And a week off was really rejuvenating. I actually managed to do it without much work. I won't say that I didn't answer emails, but it was a really quiet week and really, really powerful. That's my win.
That's fantastic. My win's on similar lines. I was spent the week chasing my kids around the beach. My wife made it very clear that she was not going to be in the sun too much. So all of those fatherly duties fell onto me. And I was mentioning that today, and somebody's like, well, someday they won't want you to chase them. It's like, oh man, okay. But yes, my skin went several shades darker. I truly look like a Filipino American now. And many patients have commented about how I'm glowing and radiant. So clearly the vacation must have worked.
You are glowing. I can only agree. Awesome. All right. Well, it's been fun.
It has been. See you for the next one.
All right.